The helicopter came down through 30-knot winds and zero visibility, and the pilots didn't ask permission to land. Just landed. 4 Navy operators hit the rooftop in full tactical gear, weapons slung, moving fast through the door and straight down the stairwell toward the emergency department. Behind them, 2 corpsmen carried a man on a litter who was bleeding from places that didn't have names in any civilian trauma manual. Their commander pushed through the ER doors, scanned the room once, and said a name. Not a doctor's name, not the chief of staff. A nurse. The same nurse 3 doctors had laughed at that morning. The same woman the senior surgeon had told, in front of 6 witnesses, to stay out of the way. They were about to find out exactly who they had been laughing at. If you're new here, hit subscribe right now, because this channel is where the stories they don't tell you out loud finally get told. Every week, we bring you real drama fiction that will keep you up at night. Hit the like button, drop a comment with your city and country. I want to see how far this story has traveled. Don't go anywhere. This one gets loud. The city of Caldwell Bay, Washington, sat wedged between a mountain range and the coast in a way that made every winter storm feel personal. The weather didn't just pass through it, arrived like something with a grudge. By mid-November, the locals had already learned to keep their gas tanks full and their pantries stocked, because when the storms came off the water, they came hard and they stayed. Mercy Ridge Medical Center was the only Level 2 trauma facility within 60 miles. It served the county, parts of 2 neighboring counties, and whatever logging and shipping accidents the surrounding region decided to produce. ER ran lean, the staff ran tired, and the administrative pressure to move patients, clear beds, and hit metrics ran constant. It was not a gentle place to work. It was especially not a gentle place to be new. Sara Nolan was 28 years old, and she had been at Mercy Ridge for 4 months. She had transferred from a small rural clinic in eastern Washington, at least. That was what her file said, and nobody had looked much deeper than that. She was quiet in the way that either meant shy or careful, and most of the staff assumed shy. She kept her head down. She double-checked everything. She never rushed, never cut corners, and never pushed back when someone redirected her, even when the redirection was wrong. She was also the person who had, 8 months prior, stabilized 4 critically wounded soldiers in the back of a moving vehicle during a night evacuation in conditions that would have overwhelmed a full surgical team. But Mercy Ridge didn't know that part. What Mercy Ridge knew was that Sara Nolan was the quiet nurse who sometimes asked too many questions and didn't seem to understand her place in the department hierarchy. Dr. Marcus Thorne made sure she understood it. Thorne was 44, broad-shouldered, and carried himself through the ER like a man who had been told he was excellent. So many times, he'd stopped examining whether it was true. He was a trauma surgeon by training, the senior attending in the department, and he had been at Mercy Ridge for 11 years. Staff respected him, mostly because they were afraid not to. He had a way of cutting people down that felt almost clinical precise, targeted, and delivered with just enough deniability that nobody ever wrote it up formally. He had decided, somewhere around Sarah's 3rd week, that she was going to be a problem. Not because she made mistakes. She didn't. She was meticulous in a way that should have been an asset. Problem was that she sometimes noticed things before he did, and Marcus Thorne did not like being noticed second. Started small, the way these things always do. Tuesday morning in mid-November, shift change, the department running at moderate capacity. Sarah was finishing a check on a post-op patient in Bay 4 when she picked up on something in the monitor readings, a subtle arrhythmia pattern that wasn't in the overnight notes. She flagged it, marked it in the chart, and mentioned it quietly to the outgoing nurse. Thorne happened to be standing nearby. He looked at the chart, looked at Sarah, and said, loud enough for the nurse's station to hear, "Do you know what a sinus arrhythmia is? Or are you just marking things to make yourself look busy?" Sarah kept her eyes on the chart. "I know what it is, doctor." Thorne. "Then you know this is normal variant, and not worth bothering anyone about." She didn't answer. She put the chart back and moved on. The arrhythmia resolved on its own. Thorne counted that as confirmation he was right, which was not quite the same thing as actually being right, but the distinction didn't bother him. 2 weeks later, Sarah flagged a medication dosage in a pediatric case, flagged it quietly, pulled the prescribing nurse aside, said it as a question rather than a correction. The nurse double-checked, realized Sarah was right, fixed it before the medication went out. No incident report, no drama. The child never knew anything had happened. Thorne found out about it through the grapevine and called Sara into the hallway that afternoon. I heard you question Dr. Petrakis's dosage order. I had a question about the weight conversion, Sara said. Nurse Delgado to verify. You went around the prescribing physician. Clarifying question. He studied her for a moment with the particular look of a man deciding how much force was necessary. You're new here. New means you don't have the experience to know when something is a problem and when it's just outside your knowledge base. The appropriate response when you're unsure is to ask a senior physician, not to go sideways through the nursing staff. Understood, she said. He waited for more. She didn't give him more. That bothered him more than the original incident. After that, it became a pattern. Thorne would find something Sara had done and reframe it as overreach. A vitals observation she'd documented carefully became excessive notation that clutters the record. A question she asked during a trauma bay briefing became disrupting workflow with unnecessary commentary. Once, when she suggested a different positioning for a patient experiencing respiratory distress, a position she'd seen save a soldier's life in a forward operating base where they had no ventilator, Thorne waved her off in front of 4 people and told her to leave the clinical decisions to people with clinical training. Patient was repositioned 20 minutes later when Thorne noticed the same thing she had. Nobody mentioned that part. Charge nurse Donna Rafferty was 41, efficient, and had survived 11 years under Thorne by learning exactly which battles to fight and which to step around. She wasn't cruel exactly. She was practical in a way that had calcified into something harder over time. She took her cues from Thorne because Thorne was the power in that department, and power in a hospital has a way of redistributing itself toward whoever already has the most. Rafferty had decided, after watching Thorne's behavior toward Sara repeat itself over several weeks, that Sara was probably not going to last. People who didn't learn to manage Thorne didn't tend to stay. She filed that conclusion under unfortunate but predictable and adjusted her own behavior accordingly. Less direct with Sara, less inclined to back her up, more willing to let the small slights slide rather than challenge them. Sara noticed. She didn't say anything about it. She kept working. She got to the hospital early every shift. She stayed late when there were patients who needed the extra attention. She read every chart in her section before the shift started and built mental maps of who was at risk, who was trending the wrong direction, who was going to need something before they asked for it. She was doing, on a civilian hospital floor, essentially the same work she had done. In the military, reading an environment, anticipating threats, staying ahead of the collapse. She was just quieter about it now. That was a deliberate choice. She had come to Mercy Ridge specifically to be quieter, specifically to be smaller. After 3 years of being attached to a special operations evacuation unit, after the last deployment, after what happened in the Corvar Valley, she wanted a job where she could help people without any of it, meaning life or death. It had not fully worked out that way, but she was trying. Storm that had been building off the coast for 3 days finally made landfall on a Thursday evening. By 7 o'clock, the wind was pushing 50 miles per hour, and the rain was coming sideways. The roads were flooding. 2 passes through the mountains had closed, and the ER, which had been running at about 70% capacity through the afternoon, was about to get considerably busier. Sara was 40 minutes into her night shift when the first wave of accident cases came through. Chain reaction collision on Route 98 vehicles, multiple injuries, 1 fatality on scene. The paramedics brought in 6 patients across 3 units, and the department absorbed them in the organized chaos of controlled emergency response. Thorne was running the trauma bay. Rafferty was managing intake flow. Sara was assigned to secondary triage in the overflow area, which was essentially a polite way of keeping her out of the primary action. She worked efficiently, moved through her patients, and kept her head down. The second wave came 40 minutes after the first. This one was worse. A storage facility near the port had partially collapsed under wind damage, and the workers trapped inside had been exposed to industrial cleaning solvents before the fire suppression system triggered. 12 patients, a mix of trauma and chemical exposure, arrived inside of 20 minutes. 2 were unconscious. 1 had a crush injury to the lower extremities. Several were presenting with respiratory symptoms consistent with solvent inhalation that nobody in the incoming team had correctly identified yet. The department went loud. Thorne's voice cut over the noise, redirecting staff, calling out orders, running the room the way he ran it fast, authoritative, and with the fixed confidence of a man who trusted his own read on every situation. His read was mostly accurate. He caught the crush injury, directed the unconscious patients to the primary bays, started the respiratory cases on supplemental oxygen. What he missed was the pattern. Sara saw it from the overflow corridor. 3 of the chemical exposure patients were presenting with delayed onset. Their initial symptoms had been mild, which meant they were being triaged lower, which meant they were sitting in chairs in the waiting area. But the delayed onset wasn't improvement. She recognized the symptom progression because she had seen it before, not in a hospital, but in a training scenario involving IDLH atmospheres, industrial hygiene, the specific way certain solvent vapors caused a biphasic pulmonary response that looked like stabilization before it became collapse. She moved to the nurse's station and pulled up what she needed to confirm, cross-referenced the solvent type from the paramedic notes, checked the expected exposure timeline, looked at the 3 patients waiting. One of them, a man in his 40s, heavy-set, work jacket still on, sitting very still, had started breathing slightly faster than he had been 5 minutes ago. Sara walked to Rafferty. I think the delayed onset group needs to be bumped up. The solvent type listed in the paramedic run sheet exposure at that concentration, in that environment, has a documented biphasic window. They're going to start crashing in the next 20 to 40 minutes. Rafferty looked at her. Dr. Thorne made the triage calls. I know. I'm asking you to bring it to him, Sara. The man in the corner chair is already showing increased respiratory rate. I've been watching him for 3 minutes. Rafferty glanced toward the waiting area. Her expression shifted, not agreement, but a flicker of something. She walked toward the trauma bay. Sara heard her mention something to Thorne, heard his response without seeing his face. He came out to the corridor himself. He looked at Sara with the expression she had come to recognize, the one he used when he was about to correct her in front of people. Rafferty tells me you think my triage is wrong. I think the delayed onset patients need monitoring. Chemical exposure profile. I know what the chemical profile is, he said. I've been a trauma physician for 15 years. I have 3 critical patients in my trauma bay right now, and I do not have time for a nurse to second-guess my triage protocol based on a paramedic's run sheet. The man in the corner is stable, Thorne said, and you are supposed to be in overflow. He turned back toward the bay. Stay in your lane. Sara stood in the corridor for 3 seconds. Then she walked to the waiting area and sat down next to the man in the work jacket. Hey, she said. I'm Sara. Can I check in with you for a second? He looked at her. His face was pale in a way that had gotten worse since she first noticed him. Fine, he said. Just tired. Can you tell me what you were working with tonight? The chemical. Floor cleaner. Industrial stuff. I don't know the name. He paused to take a breath, and the breath was slightly too deliberate for someone who was fine. There was a lot of it in the air after the tank broke. Sara put her hand on his wrist, checked his pulse. Fast. Too fast for tired. Okay, I'm going to get you into a room right now. Not because anything's wrong, just because I want to keep a closer eye. The other nurse said I could wait out here. She did, Sara said. I'm changing that. She moved him herself, got a wheelchair, settled him into Bay 6, put him on a monitor, established an IV line with saline running before anyone else came to question it. His oxygen saturation, when she checked it, was 91% and falling. She went back into the waiting area and moved the second patient, then the third. By the time Thorne came out of the trauma bay 11 minutes later, all 3 delayed onset patients were on monitors. The first man's SAT had dropped to 88. The respiratory team was already in the room. Thorne looked at the scene. He looked at Sara. You pulled these patients without authorization. Yes, she said. His jaw tightened. Get out of that room. You're off the floor. Dr. Thorne, you disobeyed a direct order and interfered with my triage protocol. You're off the floor for the rest of the shift. I want you in the administrator's office first thing tomorrow morning. He stepped closer, lowered his voice. You want to last in this hospital. You learn that you are not a doctor. You do not make clinical calls. You do not override attending decisions. And you do not embarrass this department by acting like you know something you don't know. The room was quiet around them. Staff had stopped what they were doing. Everyone was watching. Sara met his eyes. She didn't raise her voice. She didn't break his gaze. The man in Bay 6 would have coded in the waiting room, she said. His SAT is at 88. Thorne didn't answer that, pointed toward the door. Sara picked up her badge, walked to the locker room, and sat down on the bench, pulled off her gloves. She could hear the department noise filtering under the door, the monitor alarms, the voices, the particular cadence of a team managing something that had gotten bigger than expected. She sat there for a while in the fluorescent quiet. Outside, the storm was getting worse, and she did not yet know that 40 miles offshore, a military transport had declared an emergency and was trying very hard to reach Caldwell Bay before the pilot ran out of options. The storm had gotten inside the building by now, or at least that was how it felt. Pressure had changed in the hallway, not literally, but in the way that hospitals sometimes shift when everyone knows something is coming and nobody wants to be the first to say it out loud. Sara could feel it, even sitting in the locker room with the door closed. The rhythm of the department had changed. The footsteps were faster. The voices were clipped. Whatever Thorne had managed to keep contained in the last hour was expanding, and the walls weren't going to hold it much longer. She wasn't supposed to be on the floor. She sat on the bench for another 4 minutes, listening. Then she heard the overhead page, not the routine kind, not the measured tone of a standard announcement, but the flat, urgent cadence of a department being called to a mass casualty alert. 2 tones, then a voice. All available trauma personnel to the emergency department. All available trauma personnel to the emergency department immediately. She stood up, put her badge back on, and went back through the door. Nobody stopped her. The ER had transformed in the time she'd been gone. What had been organized chaos was now something denser and louder, a controlled emergency that had stopped being entirely controlled. 3 additional ambulances had arrived during the last 20 minutes, and the radio at the paramedic intake station was cycling through reports of a secondary collapse at the port facility, a section of the roof that had come down on workers who had been trying to help the first group of injured. More casualties, at least 8, possibly more. ETA unknown, because 2 of the roads feeding into the hospital were flooding. The waiting room had people standing against the walls. Every bay she could see from the corridor had a patient in it. The nurses were moving fast and quiet, in the way that meant they were past the point of talking about what needed to be done and just doing it. Thorne was in Trauma Bay 1. Through the window she could see him working on a chest case, not smoothly, because nothing was smooth right now, but competently. He was a good surgeon when the situation stayed inside the boundaries of what he'd prepared for. Problem was that the situation had already gone past those boundaries, and he hadn't noticed yet. Sara stood at the edge of the corridor and took inventory the way she'd been trained to do, not patient by patient, but system by system. What was moving? What was stuck? Where were the gaps the eye skipped over? Because it was drawn to the obvious emergency instead. The obvious emergency was in Trauma Bay 1. The gap was in Bay 7. She moved. Bay 7 had a woman in her mid-30s, unconscious, brought in as a head trauma from the Route 9 collision. According to the intake board, she'd been assessed, stabilized, and was waiting for a CT slot. Her monitor showed stable vitals, and it had been showing stable vitals for the last 22 minutes, which was exactly the kind of reading that made overworked staff feel okay about leaving a patient to wait. Sara looked at the woman. She looked at the monitor. She looked at the woman again. The monitor wasn't wrong. But the monitor was measuring what monitors measure, and it was missing what Sara was seeing, the slight asymmetry in the facial musculature, the eye movement under closed lids that didn't match what it should have been, the breathing pattern that was a fraction too regular, in the specific way that sometimes meant the brain was compensating for something it shouldn't have to compensate for. She hit the call button, pulled the light, and flagged the nurse passing in the corridor, a young man named Pete Okafor, who was 3 months newer than Sara and running on what looked like his third wind. "Get me a neuroconsult in here," Sara said now. "Think she's herniating." Pete looked at the monitor. "Vitals are, I know what the vitals are. Get me neuro. Tell them I need a stat CT head and I need it before she loses the window." She was already moving, repositioning the bed, running through the neurological check she'd memorized years before she ever touched a trauma manual. "I need to get Dr. Thorne to authorize. Thorne is in a chest case. Page Neurology Direct. Tell them Bay 7. Possible uncle herniation. Patient is a head trauma from the Route 9 MVA." She looked at Pete. He was 25 years old and had the expression of someone who understood they were watching something happen, but wasn't sure what their role was supposed to be. "Pete, go," he went. Sara worked fast. She knew the window if she was right. The patient had maybe 20 minutes before the herniation progressed, past the point where a surgical intervention could reverse the damage. Also knew she could be wrong. Head trauma was not a perfect read, even for people with years of experience, and she was working without imaging, without a full history, without backup. Could be overcalling a normal post-trauma presentation and wasting resources a department that had no resources to waste. She ran the check again. Pupil response, motor response, breathing pattern, facial asymmetry. She wasn't wrong. The neurology resident, Dr. Amara Solis, arrived in 6 minutes, which was fast, given that she'd been 3 floors up managing a completely different case. She was 31, small, and had a way of assessing a situation quickly that Sara recognized from people who had seen the inside of enough emergencies to stop being polite about what they saw. Solis looked at the patient, ran her own check, and didn't say anything for about 15 seconds. Then who flagged this? Sara said. Sara Nolan, ER nursing staff. Solis looked at her. How long have you been watching her? About 4 minutes before I called. And you got pupil asymmetry before the monitor showed anything? The asymmetry is subtle. The breathing pattern was the first tell. Solis was already on her radio calling CT. She looked back at Sara once more, with the expression of someone filing something away, and then she was fully in motion, calling out orders, getting the patient moving toward imaging. The woman went to surgery 40 minutes later. She survived. Sara didn't find out about that until much later, because by the time the surgical team was opening the OR, she was already dealing with the next thing, and the next thing after that, moving through the ER in the spaces between the sanctioned staff because no one had time to actually remove her, and Thorne was too buried in the chest case to track where she was. Apartment was running on edge, cracked at 11:47. The third wave from the port facility arrived as a loose convoy of paramedic units and private vehicles, 8 more patients, including 2 workers who'd been trapped under the partial roof collapse for over an hour. One of them, a man named Roy Barker, 53 years old, construction foreman, came in alert and talking, which was how he fooled the intake team. He was walking with help. He was answering questions. He was making jokes about the weather the way older men sometimes do when they're scared and don't want anyone to know it. Sara was at the intake desk when they brought him through. She watched him walk. She watched the way he favored his left side without seeming to notice he was doing it. The slight stiffness that wasn't just cold or fatigue, the way he moved his right arm less than he moved his left. She fell into step beside the paramedic handling his intake. What was his mechanism? She said, keeping her voice low. Paramedic, a woman named Gracie Faulkner, whom Sara had worked alongside 3 times before, glanced at her clipboard. Crush. He was under a partial roof section. They got it off him fast. He was on his feet within a couple minutes. No loss of consciousness. How long was he pinned? About 8 minutes, they think. Chest and left shoulder took most of it. His BP is a little elevated, but he's talking fine. Neuro is intact. Sara kept pace with them toward the triage station. Did anyone mention a belt? Gracie looked at her. What? His belt? When they pulled him out, was he still wearing it? Was it moved? Gracie's brow came together. I didn't get that detail. Roy Barker had been guided to a chair in the secondary triage zone. He was looking around the department with the wide-eyed interest of someone who'd never been inside an ER on a bad night, which meant he was probably better at hiding discomfort than most. Sara crouched down to his level, crouching instead of standing over him, because people talked differently when you weren't looking down at them. Mr. Barker, she said. I'm Sara. I'm going to be helping with your assessment tonight. Questions? Go ahead, he said. His voice was steady. It's not like I'm going anywhere in this weather. When they got the beam off you, where did you feel the pressure first? Where did it hit? Thought about it. Most people didn't think about it. They just said my chest or my shoulder and pointed vaguely. Roy Barker thought about it with the deliberateness of a man who spent his days managing physical spaces. Lower, he said finally. It wasn't my chest first. It hit low across my lap, kind of. Then my left shoulder when I tried to push up. Did you feel any pain in your abdomen when they moved you? Pause that lasted just slightly too long. Some pressure. They said that was normal. Is it still there? Another pause. A little. Sara looked at his color. She looked at the way he was sitting slightly forward, slightly guarded in a way that wasn't visible unless you were looking for it. She looked at the way his hands were resting on his knees, and the way the knuckles of his right hand had slightly more color than the rest of his fingers. I'm going to get you into a room, she said. Not the waiting area. A room with a monitor. I thought the nurse up front said I was... She was working from the paramedic report. and the paramedic report didn't have all the information. I'm not saying anything is wrong. I'm saying I want a better look before I'm sure nothing is wrong. Studied her for a second. You're a good liar, he said. She met his eyes. I'm trying not to lie to you at all. He let her help him up. She got him to Bay 9, got him on a monitor, established access. His blood pressure, which had been elevated on intake, had shifted not dramatically, but in a direction that, combined with the mechanism and the abdominal tenderness he'd admitted to, under direct questioning, built a picture she didn't like. She needed imaging. She needed a surgical consult. She needed both of those things to happen in the next 15 minutes. She went to find Rafferty because Thorne was still in the chest case, and Rafferty was the person who could get things moving without a direct physician order if she chose to. She found Rafferty at the central station, managing 3 things simultaneously, with the practiced exhaustion of someone operating past their limit and unwilling to admit it. I need a surgical consult in Bay 9, Sara said. Construction foreman from the port collapse. I think he has a splenic injury, possibly a grade 2 or 3 laceration. He presented ambulatory and talking, so he got triaged low, but his mechanism was underreported. He took the primary force across his abdomen. Rafferty looked up. There was something in her expression that had shifted since earlier in the night, not warmth exactly, but a slight loosening of the deliberate distance she'd been keeping. Supposed to be off the floor. I know. Rafferty pressed her lips together. She looked at the board, looked at the corridor toward Bay 9, looked back at Sara. Can't go over Thorne again. Not tonight. Not after. I'm not asking you to go over him. I'm asking you to page surgery directly on a potential abdominal emergency. Thorne is in the middle of a chest case. This doesn't have to involve him right now. Rafferty held her gaze for a long moment. Then she reached for the phone. Dr. Petra Holst from General Surgery arrived in 8 minutes, did a brief assessment, ordered an emergency ultrasound, and had the results back in 12. Free fluid in the abdomen. Splenic laceration confirmed. Roy Barker went to the OR 27 minutes after Sara had first watched him walk through the ER doors. He lost a significant amount of blood during the procedure, but the surgical team caught it before the point of no return. Sara was standing at the nursing station making notes when Thorne came out of the trauma bay for the first time in 2 hours. He looked tired. His scrub cap was pushed back on his head, and he had the slightly dazed expressions of someone who had been operating at maximum output for too long. Scanned the department board, looking for his next crisis, and then he looked at the bay assignments. He saw Sara's name on 2 active assessments. He crossed the floor toward her, and his voice, when he spoke, was not loud but was very precise. Told you to leave the floor. Sara set down the pen. She turned to face him. There are currently 2 patients in this department alive because I stayed. That is not your determination to make. With respect, Dr. Thorne, the patient in Bay 9 had a splenic laceration. He presented ambulatory on the paramedic intake and got triaged to the waiting area. He was 30 minutes from a hemorrhagic crisis. Thorne's jaw tightened. Who authorized the consult? Nurse Rafferty contacted surgery directly while you were in the chest case. He looked at Rafferty, who was standing 12 feet away, and had made no effort to pretend she wasn't listening. Her expression was neutral in the specific way that meant she was not going to back down, but was also not going to escalate. Thorne looked back at Sara. You went around me. Again. I went around you because the patient couldn't wait for you to finish a surgery, Sara said. Her voice was calm. Not deferential, not aggressive, just steady, the way it got when she wasn't managing her tone anymore, just talking. I would have come to you first if that had been possible. It wasn't possible. You are a floor nurse. You don't decide what's possible. Tonight I do, she said, because there isn't anyone else making those calls right now. Corridor went quiet around them. A monitor beeped from somewhere. The rain hammered the windows. Somewhere in the back of the department, a door swung open and a paramedic radio crackled with a traffic update. Thorne stared at her for a long beat. The look on his face was complicated fury, layered over something she couldn't fully read. Something that might have been the beginning of uncertainty, pressed down hard under the more familiar emotion. You're done, he said. Not just tonight. I'm filing a formal complaint with administration. By this time tomorrow, I want your employment status reviewed. He said it loud enough for the nurse's station to hear. Sara held his gaze. She felt something move in her chest, not fear, and not anger either. Something older than both of those. The feeling of standing on ground that had already been tested in conditions worse than this and had not given way. Okay, she said. Just that. Just the one word. Thorne waited for more, and when he didn't get it, he turned and walked back toward the trauma bay. Sara turned back to the nursing station, picked up the pen, and finished her notes. Rafferty appeared at her elbow a minute later, voice low. You should probably go take a break before he comes back out. I'll go when the board clears a little. Sara. Rafferty paused. When she spoke again, her tone had shifted, not professional distance, but something more human and more tired. I need you to understand that I can't fight Thorne on this. I want you to know She stopped, started again. Patient in Bay 9. You caught something I didn't catch. I was at that intake desk when they brought him in. Sara looked at her. Rafferty's expression was difficult. It was the look of a person who had been telling themselves a practical story for a long time and had just run into a fact that didn't fit the story. I can't promise anything will be different tomorrow. Tonight I want you to know I saw it. Thank you, Sara said. She meant it, without qualification or calculation. Rafferty nodded once and moved away. Storm peaked at midnight. Power went out at 12:34, not fully, because the hospital's generators kicked in within 8 seconds, but the transition was enough to make every monitor in the building trip and alarm simultaneously. A wall of sound that lasted for about 3 seconds and felt longer than that. The emergency lights shifted the ER into a different kind of light, harder and more honest, the kind that showed everything without softening. Sara was in the corridor outside Bay 6, checking on the chemical exposure patients she'd moved earlier, all 3 of whom were now stable, all 3 of whom had, per the respiratory team's assessment, been within an hour of serious pulmonary compromise when she'd escalated them, when her phone buzzed with an internal message from the charge desk. She looked at it, then she looked at it again. It was from the hospital's security desk, at the main entrance. The message was brief and factual in the way that security desk messages always were, but the content of it was not brief or factual in any way that fit into the rest of the night she'd been having. Military personnel at main entrance. Navy. 4 individuals armed, requesting ER access, carrying 1 critical patient on a litter. They are asking for a specific staff member by name. Security Officer D. Mwangi Sara read the message twice. Then the second message came through, 30 seconds after the first. The name they're asking for is Sara Nolan. They're calling her a rank, calling her major. She stood in the corridor for 3 seconds. The door at the end of the hall swung open, and the night changed direction entirely. She heard them before she saw them, the specific sound of tactical boots on linoleum, a rhythm that was different from hospital footsteps in a way that was hard to describe and impossible to mistake. 4 individuals moving fast and coordinated, 2 of them flanking a wheeled litter, 1 of them on the radio, 1 of them scanning the room with the practiced efficiency of someone assessing a new environment for threats and access points. Their commander was a woman, Commander Lena Vasquez, Navy, compact, 40 years old, and carrying herself like a person who had spent most of those years in places where moving wrong got people killed. She had a cut above her left eye that had been field-dressed and not properly treated. She scanned the ER until she found Sara. She walked directly to her. Major Nolan. Not a question. Sara felt the word land on her the way the old name always landed, like something she'd set down a long time ago, and was surprised to find still had weight. I'm not Major anymore, Sara said. I'm a nurse. Vasquez looked at her steadily. You're whatever we need you to be tonight. We have a critical patient, and we've been in the air for 40 minutes, in a storm that tried to kill us twice. The field surgeon we had on the transport is down. She took shrapnel during the incident, and she's one of our casualties. The nearest military medical facility with capacity is 2 hours out, and he doesn't have 2 hours. Sara's eyes moved to the litter. The man on it was in his mid-40s, uniform stripped at the torso, field dressings at the chest and upper abdomen. His face was the color of old concrete. The corpsman monitoring him was squeezing a fluid bag manually, which meant the IV was running wide open and they were still trying to keep up. What happened? Sara said. Classified incident offshore. Vessel fire, secondary explosion. He took blast and fragmentation injury. We've got a tension pneumo that was decompressed in the field, but we think there's ongoing bleeding we couldn't source. Sara was already moving. Bay 2, she called out. I need Bay 2 cleared now. I need a chest tray. I need Oneg on ice, and I need doctor. Holst paged back to the ER. She looked at the corpsman. What's his pressure? 78 over 50 and dropping, the corpsman said. Was 90 when we landed. How long ago was that? 6 minutes. 6 minutes to drop 12 points of systolic. She did the math without thinking about it. They had very little time, and the time was shrinking. She pushed through into Bay 2, and the Navy team moved with her. And she stopped thinking about Thorne and the complaint and the morning meeting and all of it, because none of that was the problem in front of her. Problem in front of her was a man bleeding out on a table in a civilian hospital in the middle of a storm, and she was the most qualified person in the building to do something about it. She reached for gloves. Behind her, at the edge of the bay, she heard Thorne's voice. He'd followed them from somewhere, drawn by the sound of the military team moving through his department, and he was standing in the doorway processing what he was seeing with the expression of a man whose categories had just stopped working. "What is this?" he said. "Who authorized? Stand aside, doctor," Commander Vasquez said, and her voice had the particular quality that came from years of saying things once and expecting them to happen. Thorne looked at Vasquez. He looked at Sara, already gloved and assessing the patient, moving with a certainty he had never seen from her in 4 months of working in the same building. He looked at the patch on Vasquez's shoulder. He stepped aside. Sara's hands found the patient's chest, felt what she needed to feel, heard what she needed to hear, and in that first 30 seconds of assessment, she understood the shape of what they were dealing with, not just the injuries, the sequence, priority, path through the next critical minutes that gave this man the best chance of still being alive when the surgical team arrived. She looked up at the corpsman across the table. "What's his name?" she said. "Captain Riordan," the corpsman said. "Captain James Riordan." She looked at James Riordan's face. He was barely conscious. His eyes were half open, tracking nothing, but there was something still present in them, not awareness exactly, but the particular quality of someone who was not ready to go. "Okay, Captain," she said quietly. "I've got you." She straightened up, and when she spoke next, it was to the room. "I need suction, I need a thoracostomy tray, and I need someone to get me an ultrasound probe in the next 90 seconds. We're going to find where he's bleeding, and we're going to hold him together until surgery gets here." Her voice carried the full length of the bay, clean and certain, and there was not a single person who heard it and questioned it, not even Marcus Thorne, who was still standing in the doorway, who was watching the nurse he had tried to erase perform battlefield medicine with her bare hands in his emergency department, who was beginning, for the first time in 11 years, to understand that expertise did not always arrive in the shape he was expecting. Ultrasound probe arrived in 81 seconds. Sara found the bleed in 3. She found the bleed in 3 minutes, and what the ultrasound showed her was not good. The probe tracked across Captain Riordan's abdomen in Sara's right hand, while she mentally mapped what was appearing on the screen. Free fluid pooling in Morrison's pouch, more in the left paracolic gutter, the spleen showing a disruption at the inferior pole that was still actively weeping. Chest was a separate problem. The tension pneumo had been decompressed in the field, but the lung wasn't fully re-expanding, which meant either the decompression had been partial or there was a secondary source she hadn't found yet. 2 active bleeding sites, 1 compromised lung, a pressure that had dropped to 74 systolic in the time it took her to run the scan. She pulled the probe back and looked at the corpsman. "When did he last have morphine?" 35 minutes. "Field dose. Don't give him more. I need him as conscious as we can keep him." She turned to the closest ER nurse, Pete Okafor, who had followed the military team into Bay 2, with the expression of someone who had decided to stop being surprised by anything tonight. "Pete, I need a second large bore IV, left antecubital if you can get it, and get me the level 1 infuser we need to run the next unit of ONEG under pressure." "We're almost out of ONEG," Pete said. "Blood bank called up 10 minutes ago. They're holding 2 units for the OR cases. How many units do we have available right now?" 1, maybe 2 if they release from the reserve. Sara did not react to that in any visible way. She processed it, filed it under constraints to work within, and moved on. "Get me the one we have and call blood bank. Tell them we have a hemorrhagic patient in traumatic arrest range with a military priority designation. They'll release the reserve." She wasn't certain they would release the reserve, but she said it like she was certain, because the room needed certainty more than it needed accuracy in that moment. Commander Vasquez was standing at the foot of the bed, watching with the contained intensity of someone who had sent people into situations with worse odds and had learned to watch without interfering. One of her operators, a big man named Petty Officer Dale Marsh, had positioned himself near the door, not blocking it, but present in a way that communicated the team had not fully stood down. "How long until your surgeon gets here?" Vasquez said. "I paged her 6 minutes ago," Sara said. "She was already in the building. 5 minutes, maybe less. And if she's not here in 5 minutes..." Sara looked up from the patient. "Then I keep him alive until she is." Vasquez held her gaze for 1 second, then nodded. Thorne was still in the doorway. He had not left, and he had not entered. He occupied the threshold in a way that was becoming harder to categorize, not the authority figure, not the antagonist, not quite a bystander. Something between those things. Watching the nurse he'd spent 4 months diminishing work at a level that was reaching everything he thought he understood about her. He was smart enough to know what he was seeing. He was stubborn enough that it hadn't finished reorganizing his understanding of it yet. Sara pushed past the threshold question because it wasn't useful. She focused on the chest. First, the abdomen was bleeding, but the respiratory compromise was the faster clock. She needed the lung re-expanding before the pressure got any lower, or the heart would start compensating in ways it wasn't built to sustain. "Captain Riordan," she said loud and direct. "Can you hear me?" His eyes moved. Not to her, exactly, but in the direction of the sound. "I'm going to need you to try to stay with me. I know you're tired. Don't go to sleep yet." The corpsman looked at her across the table. "He's been in and out since we landed." "I know." She was already setting up the thoracostomy tray chest tube placement, not ideal in these conditions, but necessary. The re-expansion wasn't going to happen on its own, and they couldn't intubate him without risking the pressure cascade that would end the conversation entirely. "Tell me about the blast." "Proximity, 15 feet, maybe less. Portside explosion." He was on deck. The fragmentation pattern went right to left that caught his vest, but the lower chest and upper abdomen were exposed. "Any penetrating fragments still in?" X-ray on the transport showed 2 retained fragments, upper left quadrant. Field surgeon marked them before she went down. Sara filed that. The fragments were not her immediate problem unless one of them shifted, which was a low probability event she couldn't prevent anyway. Her immediate problem was the chest tube, which she was now placing, with Pete holding retraction, and the corpsman managing the fluid bag overhead. Procedure was not clean. It never was. In real conditions, in real emergencies, on patients who were moving even when they were trying to hold, still because the body didn't stop having reflexes, just because the situation was serious. Riordan flinched when the trocar entered, made a sound low in his throat, and his pressure dropped 4 points on the monitor before leveling. Sara kept working. When the tube was seated and the water seal established, she listened. The air moving out was audible, a good sound. The sound of pressure releasing, and the monitor's oxygen saturation, which had been sitting at 87%, began a slow climb. 88, 89, 91. Pete let out a breath he'd been holding. "Okay," Sara said quietly. "Not good, not perfect, just okay," which was the only honest word for it. One problem partially managed. The abdomen was still bleeding. Pressure was still 74, and the blood bank hadn't called back yet. She straightened up and turned to find Dr. Petra Holst standing behind her. Holst had arrived without fanfare, had apparently slipped in during the chest tube, and positioned herself to observe without disrupting. She was still in her surgical scrubs from the OR upstairs, mask pulled down around her neck, and she was looking at the patient with the careful attention of someone who had already started building the operative plan. "Brief me," Holst said. Sara briefed her in under 90 seconds mechanism, timeline, field interventions, current imaging findings, fluid status, the fragment locations, the chest tube output. She spoke in the clipped, structured format she'd learned in the military, the kind where you front-loaded the information that changed the decision-making and left out everything that didn't. Holst listened without interrupting. When Sara finished, Holst said, "He needs the OR." "Yes." "How long can you hold him?" "His pressure is 74 and I have 1 unit of ONEG left. If blood bank releases the reserve, maybe 20 minutes before the math stops working." Holst turned to the door and her voice went loud. "I need OR2 prepped now. I need the second attending on call, and I need them scrubbed in 12 minutes. Tell them it's a military trauma, penetrating abdominal injury, active hemorrhage." She looked back at Sara. "You did the ultrasound?" "Yes." "Spleen?" "Inferior pole disruption, active hemorrhage. Morrison's pouch and left paracolic gutter, both showing free fluid. I'd estimate at least 1.5 liters in the abdomen already." Holst nodded. Okay, she looked at Riordan. She looked at Sara. You held them together. It wasn't a question, but Sara answered it anyway. So far, the blood bank released the reserve. Took 11 minutes and a phone call from the hospital's medical director, who had arrived on site 20 minutes earlier. After the mass casualty alert reached administrative channels, Dr. Howard Strauss, the medical director, was 61, wore reading glasses that he kept losing and finding on top of his own head, and had the general affect of a man who had managed institutional crises for long enough that very little genuinely surprised him. He was surprised by what he found in Bay 2. He stood at the doorway, the same doorway Thorne had been occupying. Though Thorne had finally moved off to somewhere else in the department and watched Sara coordinate the final preparations for Riordan's transfer to the OR. Watched her communicate with the Navy corpsmen in the specific shorthand of people who had shared a professional language. Watched her hand off to Holst's team with the clean efficiency of a handoff that had been practiced until the practice became instinct. Strauss had read Sara Nolan's personnel file when she was hired. He remembered it as unremarkable rural clinic background, solid nursing credentials, letters of reference that were complimentary without being specific. He was now standing in his own emergency department, watching her operate with a competence that didn't fit the file, and he was a careful enough administrator to understand that the gap between the file and the reality in front of him was going to need explaining. He did not approach her yet, he simply observed. Commander Vasquez appeared at his elbow. Dr. Strauss, she said. She had clearly identified him before he'd identified her, which was consistent with everything else she'd done since arriving. I need 5 minutes when you have them. You can have them now, he said. Stepped into the corridor. Riordan went to the OR at 1:17 in the morning. Sara watched the gurney disappear through the double doors, and then stood in the suddenly quiet Bay 2 and let herself breathe for the first time in what felt like an hour, but had actually been 23 minutes. 23 minutes of sustained focus at a level that left a specific kind of residue, not exhaustion exactly, but a hollowing out, a depletion of something that wasn't quite physical and wasn't quite emotional, but was the combination of both pressed into a single's sustained effort. Pete Okafor was breaking down the bay beside her, moving efficiently and quietly, and he said without looking up, "Where did you learn to do that?" Sara peeled off her gloves. "Do what?" "All of it." He paused with a blood pressure cuff in his hand. "Chest tube. The ultrasound. The way you talk to the Navy people like you'd worked with them before." She considered not answering. But Pete had been beside her for the last hour, without flinching, handing her things before she asked for them, managing the room logistics while she focused on the patient. And he had done it because he'd read the situation and made a decision to support her, even when the institutional authority in the room was telling him not to. He had earned an honest answer. "I was a critical care medic," she said. "Military. Special Operations Evacuation Unit." Pete looked at her. "How long?" 6 years active. 3 of those attached to soft units. He was quiet for a moment, processing this against 4 months of watching her. Be careful and quiet and invisible. "And then you came here." "And then I came here," she said. He nodded, with the particular nod of someone who understood they were only getting the outline and respected the boundary of what they weren't being told. "Okay," he said, and went back to breaking down the bay. It was a good response. Sara filed it away as the best response anyone had given her to that information in a long time. Vasquez found her 20 minutes later. Sara was at the nursing station, writing up her documentation, the kind of documentation that was going to be complicated to file, given that she'd spent most of the shift operating outside her sanctioned scope, but which needed to exist for the patient's records, regardless of what happened to her employment status tomorrow. She was trying to be methodical about it and mostly succeeding. Vasquez sat down across from her without asking. "Doctor, Strauss wants to talk to you," she said. "I figured. Before that happens, I want to tell you something." Sara kept writing, but gave Vasquez her attention in the way she'd learned to manage in the field, physically present to the task in front of her, mentally present to the conversation. "When you left the unit," Vasquez said, "there were people who didn't understand it, myself included." Sara set the pen down. "You were the best medic in the evacuation element. Not the best female medic, the best medic." Vasquez said it the way people stated facts they considered settled. "The Corvar Valley mission, what you did in those 18 minutes, has been studied at the training center. They don't use your name because the mission is still classified, but the procedures are in the curriculum." Sara was quiet for a moment. That's not why I left. I know why you left. The two women looked at each other, and there was something in the air between them that was too complicated to name. Shared history and shared loss, and the specific weight of what happened in the Corvar Valley, which Sara did not talk about and was not going to talk about now, and which Vasquez understood well enough not to press. Riordan asked for you specifically, Vasquez said. When we got the call that the nearest facility was Mercy Ridge, he told us. Said if Sara Nolan was still there, she'd keep him alive. Sara felt something shift in her chest. He knew I was here? We track our people, Vasquez said simply. Not to bring you back, just to know. The weight of that settled somewhere complicated. Sara picked up the pen again and looked at her documentation without writing anything for a moment. Is he going to make it? Vasquez asked. Holst is one of the best abdominal surgeons in the region. If anyone can close what I found on that ultrasound, it's her. She paused. He was alert enough to stay present through the chest tube. That's not nothing. Vasquez nodded. Then she said carefully, the physician who told you to leave the floor. Thorne, Sara looked up. I spoke with Dr. Strauss. I told him what I observed when we came in. The patient in Bay 2 had been in this building for 3.5 minutes when you had him assessed, tubed, and stabilized. The team that brought him here, combat-experienced Navy corpsmen, were watching you work. Those men have seen field medicine at the highest levels. They don't impress easily. Commander, I'm not done. Vasquez's voice wasn't unkind, but it was final in the way that command voices got, when the speaker had decided something and was communicating it rather than discussing it. Formal complaint Thorne filed tonight. I understand there's a process, but I want you to know that I have submitted a written statement to Dr. Strauss detailing what I witnessed in this department over the course of the last 2 hours. That statement will be part of whatever record exists. Sara held her gaze. You didn't have to do that. No, Vasquez agreed. I didn't. She stood, straightened her jacket, and looked toward the double doors where Riordan had disappeared. Stay on the floor tonight, she said. I don't care what Thorne said. She walked away. At 2:40 in the morning, the storm began its first real retreat. Not finished, the rain was still heavy, the wind still gusting, but the sustained assault had broken. The pressure differential that had been battering the coast for 6 hours finally starting to even out. You could hear it in the building. A subtle shift in the way the windows were vibrating. A half-step decrease in the ambient roar that had underlaid everything since 9 o'clock. The department was still busy, but it had found a different rhythm, the rhythm of maintenance rather than crisis, of holding the line rather than fighting for ground. The critical cases had either been resolved or transferred. The census was high but manageable. Staff had started eating things from their pockets and leaning against walls for 30 seconds between tasks, which was the hospital equivalent of coming up for air. Sara was checking on the chemical exposure patients in Bay 6, all 3 stable, all 3 sleeping, when she heard the raised voice from the direction of the administrator's office at the end of the corridor. Not Thorne's voice. Thorne's voice she would have recognized immediately. This was different. Male but younger, tighter, with the edge of someone making an argument they could feel slipping away from them. She didn't go toward it. It wasn't her business, and she had patience to finish checking. But Pete Okafor materialized beside her 2 minutes later with the expression of someone carrying news they didn't know how to categorize. Administration is here, he said. Not just Strauss. Someone from the board, I think his name is Hargrove. And they've got Thorne in that office. Sara kept her eyes on the chart. That's between them. They've been in there for 20 minutes. Rafferty was called in about 10 minutes ago. He paused. People are saying you're going to be fired in the morning. People said that earlier tonight, and I'm still here. Sara. She looked up. Pete's face was 25 years old and unguarded in a way that most faces in this building weren't. What you did tonight, the man in Bay 9, the 3 exposure patients, the military guy if that gets buried. Because Thorne, it won't get buried, she said. It wasn't wishful thinking. Calculation based on what Vasquez had told her, on what Holst had seen, on the fact that Roy Barker and 3 other patients were alive because of interventions that would appear in the medical record, regardless of what happened to her employment status. The record was the record. That part was permanent. Pete seemed to take something from for certainty, even if he didn't fully understand where it was coming from. He nodded, started to move off, then turned back. The old guy, Barker, from the port. What about him? His family came in an hour ago. His wife and his daughter. They were asking who found the internal bleed. He paused, told them a nurse named Sara caught it. Sara looked at him for a moment. Okay, she said. Just that, with the same weight she'd given it to Thorne hours earlier, but entirely different in meaning. The OR called at 3:11. Sara took the call at the nursing station. Holst's voice came through clipped and professional, and carrying the particular quality of a surgeon who had done something difficult and done it correctly, and was ready to report the result. Riordan closed. Splenectomy, hemorrhage controlled. The fragment in the upper left quadrant was closer to the bowel than we wanted, but we got it out clean. He's going to recovery now. A pause. He's stable, Sara. He made it. Sara kept her voice even. Thank you, doctor. Holst, don't thank me. Your stabilization bought us the window. Without the chest tube and the pressure management, we'd have been working on a corpse. Another pause, shorter. I've written it up that way in the operative report. Specifically, the line went quiet. Sara set the phone down and stood at the nursing station for a moment without moving. Then she went back to work. At 3:47, the administrator's office door opened. Thorne came out first. She saw him from the corridor. She wasn't watching for him, but she was moving past the end of the hallway when the door opened, and their sightlines intersected for a second before either of them could recalibrate. He looked different. Not smaller, exactly, because Marcus Thorne was not a man who visibly diminished easily. But something had changed in the set of his posture. The high-held certainty she'd watched carry him through 11 years of this department had shifted, and what replaced it was not humility so much as the expression of a man who had just been shown a room in his own house that he didn't know existed. He looked at her. She looked at him. Neither of them said anything. He turned left and walked toward the physician lounge, and he did not look back. Board member Gerald Hargrove appeared in the doorway behind him. He was 63, gray-haired, the kind of institutional figure who dressed the same at 3 in the morning as he did at board meetings. He looked down the corridor, found Sara, and said, Ms. Nolan, when you have a moment. It wasn't quite an invitation. It wasn't quite an order. It was the language of institutional power trying to recalibrate itself toward something, and she understood what it meant well enough to know it was important. She followed him into the office. Strauss was there. Rafferty was there, seated to one side, her posture careful, and her expression doing the complicated internal work of someone in the middle of deciding something about themselves. Gez was there, standing against the wall, in the way she stood everywhere present, contained, observing. There was also a woman Sara didn't recognize, mid-50s, civilian clothes, with a laptop open on the table and a recorder running, which meant she was either legal or compliance. And the fact that she was there at 3:47 in the morning meant this meeting was not informal. Hargrove sat down across from Sara. We've been reviewing the incident reports from tonight, he said. Dr. Holst's operative report was filed 40 minutes ago. We've reviewed Nurse Rafferty's account, Commander Vasquez's written statement. He folded his hands on the table. We also have the formal complaint Dr. Thorne submitted against you at 11:52. Sara kept her hands still on the table. In the interest of being direct, Hargrove said, We are not here to discuss your termination. He paused to let that land. We are here because what happened tonight in this department has raised questions about a number of things, and your role in tonight's events puts you at the center of all of them. What kind of questions? Sara said. Questions about patient safety protocols. Questions about triage decision-making. He looked at her steadily. And questions about how a staff member with your specific background and qualifications ended up working as a floor nurse in this department for 4 months without anyone knowing what she was actually capable of. The room was quiet. The recorder on the table kept running. And then, from the corridor outside the closed door, Sara heard something she had not expected to hear. Shouting. Not the ambient noise of a busy ER. Not a monitor alarm or a patient in distress. It was Pete Okafor's voice, sharp and urgent, cutting through the closed door with the particular edge that meant something had changed in the department. She was already out of her chair when the door opened. Pete was in the hallway, and his face had done the thing it did when things were very bad. Bay 4, he said. The head trauma from Route 9 doctor. Solis said she was stable after the surgery. She was stable. He stopped, pulled breath. He's coding. Sara was moving before he finished the sentence. And behind her, she heard Hargrove say something to Strauss, and she heard Strauss answer. And she heard Vasquez's boots on the linoleum, keeping pace with hers for 2 steps before pulling back. She hit the Bay 4 door at a run. The woman on the bed, Carla Mendez, 34 years old, Route 9 collision. The patient Sara had flagged for herniation 3 hours ago, had gone into cardiac arrest at 3:51 in the morning. The monitor was screaming. The night nurse who'd been covering the post-surgical patients was doing compressions, technique slightly off, arms not quite locked, the rate a fraction too slow. Sara moved in, took over compressions without breaking the sequence, felt the resistance under her hands, assessed the rhythm on the monitor in the same second. Pulseless electrical activity, not a shockable rhythm, which meant this wasn't a primary cardiac event. "What happened?" she said, talking over the compressions. She just went, no warning. Sat dropped, and then flatlined. "Neuroconsult now. Get Solis on the phone." She kept the compressions going, counting internally, assessing. PEA in a post-craniotomy patient, 3 hours out of surgery, the differential was short, and the top of the list was bad. Rebleed. Cerebral herniation, completing what it had started earlier, or something she was missing. "Epi," she called out. 1 milligram IV push. And get me the portable head CT on wheels. I need to see what's happening in there before we lose the window. Pete was already moving. The room filled with people the overnight attending doctor. Solis coming through on the phone, and then in person 60 seconds later, moving fast down the corridor in a way that meant she'd been close. Sara kept working. She kept working because the alternative was not working, and not working meant Carla Mendez, 34 years old, who had been alive and talking and brought into this ER by paramedics, who had gotten her out of a crumpled car on Route 9, stopped being alive. The EP went in. The monitor continued its flat, mocking pattern. Sara counted compressions and looked at the clock and ran the math in her head: duration of arrest, time to intervention, the specific cruelty of a brain that had survived something massive only to be undone in the recovery, and she did not stop. Solis was beside her now, assessing, her hands moving over the patient's skull with the careful urgency of a surgeon who needed information and needed it fast. "There," Solis said, her fingers stopping at a point above the left temporal region. Pressure. Sara felt it too, the subtle asymmetry under the post-surgical dressing that hadn't been there during the initial assessment. "Rebleed," Solis said. It wasn't a question. "How fast can you take her back to the OR?" "Not fast enough if her brain is herniating again." Sara looked at the monitor. She looked at the patient. She looked at Solis. "Then we stabilize her here until it's fast enough," Sara said. Solis stared at her for exactly 1 second. Then she said, "Tell me what you need," and Sara told her. The room reorganized itself around that answer, pulling together the way rooms did when someone had made a decision, and the decision was clear, and the only option left was to execute it. The monitor ran its flat line. Sara's hands kept moving. And somewhere in the hospital, in the recovery ward on the 3rd floor, Captain James Riordan opened his eyes, for the first time since the helicopter had landed, looked at the ceiling of Mercy Ridge Medical Center, and did not yet know that the woman who had kept him alive was currently fighting to keep someone else from dying. He didn't know. But he was breathing, and that for the moment was what it cost her to be who she was. The monitor ran its flat line for 4 minutes and 20 seconds. Then Carla Mendez came back. It wasn't dramatic in the way that television made it look. No single shock, no gasping return to full consciousness, no moment of clean resolution. It was messier than that. The epi bought a few seconds of organized rhythm that collapsed, and Sara adjusted the compression rate, and Solis pushed a second medication, and the rhythm collapsed again, and the third attempt held stuttering, irregular, weak, but present. The monitor stopped screaming and started showing something that resembled a heartbeat, and the room exhaled in the way rooms did, when the worst possibility had been narrowly avoided, without anyone being certain it was actually over. "Get her to CT," Solis said immediately. "Then straight to the OR if I'm right about the rebleed. Don't let her wait in imaging." "She'll need to be intubated for transport," Sara said. "I know, do it." Sara intubated Carla Mendez in 4 minutes on a patient whose neck position was compromised by the post-surgical dressing and whose jaw was not cooperating and whose oxygen saturation was sitting at a level that did not allow for multiple attempts. She got the tube on the second pass. She knew, distantly, that her hands were shaking slightly, not from fear, but from the accumulated physical output of the last 4 hours, and she compensated without thinking about it, the adjustment automatic and old. The gurney moved. Solis went with it. Sara stood in Bay 4 after they left and put both hands flat on the empty bed rail and breathed through her nose for 10 seconds. Pete Okafor was still in the room, cleaning up the arrest equipment, with the methodical focus of someone who needed a task to hold on to. He didn't say anything. He didn't ask if she was okay. He had figured out, sometime in the last few hours, that Sara Nolan didn't need that particular question, and asking it would have been about his discomfort more than her well-being. She appreciated that more than she could have explained. "Go take a break," she told him. "You've been moving for 6 hours straight. So have you, I know. I'll take one after you do." He put down the equipment, looked at her for a moment, and left without arguing. That was also the right call. Sara stayed in Bay 4 for another 30 seconds. Then she washed her hands at the sink, watched the water run over her knuckles, and thought about nothing specific and everything at once, the way you did after sustained crisis, the images surfacing without sequence, Riordan's pressure reading, the ultrasound image of free fluid, Carla Menz's rhythm, stuttering back to something livable, the look on Thorne's face when he walked out of that office. She dried her hands and went back to the floor. Apartment at 4 in the morning had the particular quality of aftermath. Storm had continued its retreat, the rain was still present, but the wind had dropped enough that you could no longer hear it as a constant force against the building. The waiting room had thinned. The bayboard showed a census that was high, but no longer catastrophic. Staff moved at the pace of people who had been running for hours and had downshifted into something more sustainable, the kind of tired that was functional rather than dangerous. Rafferty was at the central station. She had been at the central station, Sara realized, for most of the last 6 hours. Not because she was hiding there. Rafferty wasn't a person who hid, but because the central station was where the administrative and clinical threads of the department converged, and Rafferty had spent the night managing both with the competence that Sara had watched her deploy consistently, even when everything else in the department was fracturing. She was a good charge nurse. Sara had known that from her second week. The problem had never been Rafferty's ability. It had been Rafferty's choices about who to align with and why, and those were different categories of failing. Sara stopped at the station to update 2 charts. Rafferty watched her for a moment without speaking. Then the board meeting this morning. 7 a.m. "I know," Sara said. "Hargrove told me they're pulling incident reports going back 6 months. Rafferty's voice was neutral, but the information inside it wasn't. Not just tonight, everything." Sara kept writing. "Their process, Sara." A pause. When Rafferty spoke again, there was something in her voice that hadn't been there before. Tonight, not guilt exactly, because Rafferty was practical enough to move through guilt quickly. Particular quality of someone who had done a reckoning and was carrying the result. "I didn't back you up. Several times over the last 4 months, I didn't back you up when I should have." Sara set the pen down. She looked at Rafferty directly. "I know. I'm going to say that in the meeting this morning." Sara studied her face. Rafferty's expression was resolved in the way that meant she'd already gone back and forth with herself and had landed somewhere she was going to stay. "You don't have to do that," Sara said. "I know I don't have to." Rafferty's jaw tightened slightly. "There's a difference between what I have to do and what I should do. I've been getting that wrong for a while." It was not an apology. Exactly. It was something more honest than an apology because it named the pattern rather than just the incident. Sara recognized the distinction and filed it accordingly. "Okay," she said. She picked up the pen and went back to the chart. 5:15, Dr. Amara Solis appeared at the nursing station with the post-surgical report on Carla Mendez. Rebleed confirmed. A small arterial bleeder at the surgical site, missed during the initial closure because it had been in vasospasm at the time, the kind of thing that happened, kind of complication that post-surgical monitoring was specifically designed to catch, the kind of thing that was survivable if caught in time and fatal if not. Carla Mendez was in recovery. She was going to need another week in the ICU, possibly longer, and the neurological outcomes were uncertain, in the way that brain injury outcomes were always uncertain. But she was alive. The arrest had lasted under 5 minutes with continuous intervention, which kept the hypoxic injury window narrow. Solis gave her a guarded prognosis, which was not a good prognosis but was a real one, and real was what they had to work with. Solis set the report on the counter and looked at Sara. "The initial flag," she said, "when you moved her to a room hours ago. It's in the record." "I know. If you hadn't flagged her for the first surgery, she wouldn't have survived the rebleed. There would have been nothing to rebleed from. She'd have herniated before midnight." Solis said it with the precision of a physician who had thought it through and wanted the logic on the table. "I want you to understand that. I understand that." "Thank you," Sara said. Solus looked at her for a moment longer with an expression that was part professional respect, part something more personal, the look of someone recalibrating an understanding they'd only partially formed before tonight. Then she picked up her pager, which had begun vibrating, and moved away. The 7 o'clock meeting had been moved to 6:30. Sara found out from Pete, who found out from the overnight administrative coordinator, who had been fielding calls from board members since 5 a.m. She had 45 minutes. She used 30 of them, finishing her patient documentation, all of it. Every intervention, every assessment, every decision, and the reasoning behind it, laid out in the clear and legally precise language she'd been trained to use in environments where documentation was the difference between accountability and chaos. She used the remaining 15 minutes sitting in the break room, drinking bad coffee and looking at the wall. Coffee was genuinely terrible, burnt, thin, from a machine that had been due for replacement since the previous spring. She drank it anyway because her body needed the caffeine and the warmth more than it needed the coffee to be good. She thought about the Corvar Valley. She didn't do that often. She had built specific mental architecture around that particular memory, not walls exactly, but a structured distance, a way of holding the event in a frame that allowed her to access what she'd learned from it without being consumed by what it had cost. The architecture had taken 2 years to build, and it wasn't always reliable. Nights like this one sometimes destabilized it. 18 minutes in a burning vehicle on a mountain road, 4 critically wounded soldiers, no backup, no surgical support, a medic kit that was already half depleted from an earlier contact. She had kept all 4 of them alive until the extraction bird arrived. One of them had lost a leg below the knee. One had required reconstructive surgery on his orbital socket. 2 had returned to full active duty within 8 months. All 4 were still alive. She had left the military 4 months after Corvar because the thing that Corvar had taken from her, a specific quality of certainty, a belief that her own judgment could be trusted to operate under maximum pressure without cost, had turned out to be something she needed to grieve before she could carry it again. She had not finished grieving it, but she was further along than she'd been. She finished the coffee and stood up. The meeting was in the main conference room, not the administrator's office. That was the first signal that the scope had changed. The administrator's office was where individual matters got handled. The conference room was where institutional matters got addressed, which meant what happened in that room this morning was not going to stay between Sara Nolan and Marcus Thorne. Hargrove was already there. Along with Strauss and 2 other board members, Sara hadn't met a woman introduced as Patricia Vane, hospital legal counsel, and a man named Dr. Samuel Ost, the board's medical affairs chair, who was 70 years old, had the posture of a former military physician, and looked at Sara when she entered with the particular expression of someone who had read everything available and formed a preliminary view. Rafferty was there. Vasquez was there, still in her uniform, which meant she had not slept since the helicopter landed. And Thorne was there, seated at the far end of the table, with a legal pad in front of him that had writing on it. Sara couldn't read from where she sat. She sat down, put her hands on the table, and waited. Hargrove opened without preamble, which she respected. He recapped the night's events in the factual language of an administrator who had reviewed incident, reports the mass casualty event, the multiple patient interventions, the formal complaint from Dr. Thorne, the military patient, the post-surgical emergency in Bay 4. He was accurate and he was complete, and he did not editorialize, which told her he was either a careful man or a calculating one, and she wasn't sure yet which it was. When he finished the summary, he set the papers down and looked at Sara. Before we address the formal complaint, he said, I want to ask you directly, why didn't you disclose your military background when you were hired? The room was quiet. Sara had expected the question. She had thought about how to answer it during the coffee and the wall staring, and she had decided that the only version worth saying was the true one. Because I came here to do a job, not to manage people's expectations of me based on a history I was trying to set aside, she said. Credentials were valid. My nursing license was current. My references were accurate. What I did before nursing school was my own history to share when and how I chose to. Hargrove considered that. You weren't required to disclose it. No. But there are people in this room who might argue that the department would have utilized your skills differently if they'd known. There are people in this room who might argue that, Sara said. But what actually happened is that the department used my skills when it needed them and tried to remove me from the building when it didn't, and whether or not my background was disclosed had nothing to do with either of those decisions. Statement landed in the room and stayed there. Ose, from across the table, made a small sound that was not quite a laugh, and not quite agreement, but was somewhere between the two. Thorne's jaw had tightened. He was looking at his legal pad, and the pen in his hand had stopped moving. Patricia Vane took over from Hargrove at that point, moving into the procedural section of the meeting with the efficiency of legal counsel, who understood that efficiency was the point. The 6-month incident review, she explained, had been initiated not as a result of tonight's event specifically, but because of a pattern that had emerged when the night's documentation was cross-referenced with existing incident reports. 3 prior cases had been flagged in which Sara had noted a clinical observation been overruled by Dr. Thorne, and the subsequent record had shown that Sara's initial assessment was accurate. In one case, the overrule had contributed to a delayed intervention that was documented in the patient's chart as a complication. Complication had never been reviewed in the context of the attending's decision-making. It was being reviewed now. Thorne looked up from his legal pad. Those cases were resolved within standard clinical parameters. They were resolved, Vane said. The review is about the decision-making process, not the outcomes. The outcomes are what matters in medicine. The outcomes are one factor, Ose said from across the table. His voice was measured and very calm. The process by which clinical decisions are made and the weight given to all clinical information available is another factor. Those aren't the same thing. Thorne's expression shifted. He understood, Sara could see, that the ground had changed under him, not tonight, not in the last hour, but incrementally over the last 6 months, and the change had not been perceptible until everything was laid out in one room at 6:30 in the morning. He was looking at a picture that had been assembled piece by piece and was now complete, and the picture was not flattering. I have run this department effectively for 11 years, he said. You have, Hargrove said. That's in the record too. He paused. So is everything else. The everything else sat in the room like a physical object. Rafferty cleared her throat. Every head in the room turned toward her. She sat with both hands folded on the table, and her posture was the posture of someone who had made a decision and had organized their body around it. I want to make a formal statement, she said. For the record. Vane nodded. The recorder on the table was already running. Rafferty looked at it, then looked at Thorne. On 4 separate occasions, in the last 3 months, I was present when Dr. Thorne dismissed clinical observations made by Nurse Nolan that were later confirmed to be accurate. On 2 of those occasions, I did not support Nurse Nolan's assessment when I had sufficient grounds to do so. She stopped. Her voice was steady, but the effort of keeping it that way was visible. I made those choices because Dr. Thorne's authority in this department made challenging him costly, and I prioritized the path of least resistance over the correct clinical and ethical response. She unfolded her hands and laid them flat on the table. I want that on the record. The room was silent. Thorne stared at Rafferty. The expression on his face was something Sara had not seen from him before, not anger, not calculation, but something rawer than either of those. The look of a man whose allies were declaring their positions and finding them on the other side. Donna, he said. His voice was quieter than it had been. I'm sorry, Marcus, Rafferty said. She didn't look sorry in the collapsed sense. She looked like someone who had paid a price and accepted the receipt. But I'm not going to let this go the wrong way. The meeting ran for another 40 minutes. The formal complaint Thorne had filed against Sara was reviewed line by line. Clinical record was reviewed against it. Vasquez's written statement was entered. Holst's operative note was entered. Solis's documentation of the original herniation flag was entered. When the review was complete, Hargrove conferred quietly with Ose and Vane for approximately 4 minutes, while everyone else sat in the particular discomfort of a room in which something significant is being decided, and the deciding is happening just out of earshot. Then Hargrove looked up. The formal complaint against Nurse Nolan is dismissed, he said. He said it the way he said everything, factually, without inflection. Conduct described in the complaint is, on review, consistent with clinical necessity in a mass casualty event where sanctioned clinical leadership was unavailable or otherwise occupied. Thorne's pen stopped. Additionally, Hargrove continued, the hospital board is initiating a formal review of Dr. Thorne's conduct over the past 6 months, with particular attention to 3 specific patient cases and the complaint pattern documented in nursing staff reports. He looked at Thorne directly. Pending the outcome of that review, Dr. Thorne's attending privileges in the emergency department are suspended effective immediately. The word suspended hit the room like something dropped from a height. Thorne's face went through several things very quickly. Disbelief was first. Then the automatic preparation for argument, the reflex of a man who had argued his way through institutional resistance for 11 years and won most of those arguments. Then something else, a slow, arriving understanding that this room had been assembled specifically to reach a conclusion that argument was not going to change, and that the conclusion was not unfair, and that knowing it was not unfair was the specific part that was hardest. "Can't suspend my privileges based on a single event," he said. His voice was controlled. Barely. "We're not suspending them based on tonight," O.C. said. "We're suspending them pending review of a pattern. Tonight is what made the pattern visible." He let that settle. "The review will be thorough. If it finds what the preliminary record suggests, the board will act accordingly. If it finds otherwise, your privileges will be restored with a full record of the review's findings." Thorne stood. He straightened his jacket. He picked up his legal pad. He looked at the room, at Hargrove, at Vane, at Rafferty, at O.C., and finally at Sara, and the look lasted for exactly 1 second before he turned toward the door. "I'll be in contact with my legal representative," he said, and left. The door closed behind him. Sara looked at the space where he had been and felt nothing clean. Not satisfaction, not relief. Something more complicated, the specific weight of watching a person face consequences that were real and earned, and that were also not sufficient to undo the damage of how they'd used their time before the consequences arrived. Patients in those 3 flagged cases were still patients who had experienced delayed care. Carla Mendez was still in the ICU with uncertain neurological outcomes. Roy Barker had survived, but surviving wasn't the same as the hour he'd spent sitting in a chair in the waiting room while his spleen bled quietly. Justice had a cost that ran alongside it, and the cost didn't disappear just because the justice arrived. She sat with that for a moment. Then Hargrove said, "Miss Nolan, are you available to stay on shift?" She looked up. "The department is still running a high census," he said. "We're down an attending physician, and 2 of the overnight nurses went home sick an hour ago." He was watching her with the frank assessment of an administrator looking at a resource. "You've been on for what, 9 hours? Closer to 10. Can't officially ask you to extend, given the circumstances. But you're asking." A pause. "Yes." Sara looked at the table. Thought about Carla Mendez upstairs in the ICU and the uncertain neurological outcomes. She thought about Roy Barker's wife and daughter, who had come in and asked Pete, who found the bleed. She thought about James Riordan opening his eyes in the recovery ward. She thought about the fact that the ER was still full of people who had nothing to do with any of this and who needed a nurse who knew what she was doing. "Yes," she said, "I'm available." She was back on the floor by 7:20. The department had shifted to day staff, which meant new faces moving into a space that still held the residue of the previous night. The supply levels were depleted. The board was annotated with the handwriting of 4 different nurses from the overnight, and the particular low-grade tension of a team that had gone through something and not yet finished processing. It was present in every conversation that lasted more than 30 seconds. Pete was gone. He'd clocked out at 7, but on his way out, he'd left a note on the nursing station counter, not addressed to anyone, just sitting there, that said, "Bay 9 patient's family is asking for updates. Family contact is on the board." It was the most Pete Okafor thing he could have done, and it made Cersei feel something brief and uncomplicated in the middle of everything that was complicated. Called Roy Barker's wife at 7:35. Conversation was short and careful in the way. Medical conversations were, when the outcome was good, but the fear had been real. His wife, Margot Barker, whose voice on the phone had the quality of someone who had been awake all night with a fear they hadn't fully named, listened to Sarah's update and asked 2 questions. "Is he going to be okay? And who do I thank?" Sara answered the first honestly. He was stable. The surgery had gone well. There would be a recovery period, but the prognosis was good, and deflected the second the way she always deflected it, saying the team had worked together and the paramedics had gotten him in quickly. Joe Barker said, in a voice that had clearly decided not to be deflected. "The young male nurse told us a woman named Sara caught something the paramedics missed. That was you." Sara didn't answer for a second. "He told you the right thing," she said finally. "Then thank you," Margot Barker said. "I'd like to when he's out of recovery. I'd like to find a way to tell him to take it easy for 6 weeks. Sara said. That's all I need from you. She could hear the smile through the phone, which was rare and good. She hung up and went back to the board. At 9:47, Commander Vasquez appeared at the nursing station for the last time. She was in a different uniform travel gear, ready to leave. Her cut above the eye had been properly treated at some point in the night, closed with steri strips and cleaned. She looked like a person who had done what she came to do and was preparing to do the next thing. Riordan is being transferred to the Naval Medical Center this afternoon, she said. He's stable enough for air transport. The weather cleared. Good, Sara said. Vasquez put a card on the counter. That's my direct contact. The unit's contact through me. She paused. If you ever want to come back, I'm good here, Sara said. Vasquez looked at her for a moment. Not disappointed. She'd known the answer before she asked. Sara could tell. She'd asked because it was the right thing to offer, and Vasquez was someone who did the right thing even when she knew the answer. Then be good here, she said. This place got lucky when you walked in. She picked up her bag, nodded once, and walked toward the exit. Sara watched her go. Then she turned back to the board, because there were 11 patients on it, and some of them needed her attention and the morning was already running. At 10:15, Dr. Howard Strauss called her into his office briefly. No formal meeting, just the two of them, and the morning light coming through the window at a low angle. He told her that the board had authorized an immediate clinical review of her scope of practice with the intention of establishing a formal expanded scope protocol that would allow her to function at the level her training and demonstrated competence justified. He told her that this would take several weeks to complete, but that in the interim, she was to be extended professional courtesy, commensurate with her demonstrated expertise. He told her this in the dry, procedural language of an administrator, but underneath the language was something more direct, which was an institution trying to correct a wrong in real time, rather than waiting for the formal process to catch up to the reality. She thanked him. She went back to the floor. At 11 o'clock, she was checking on the chemical exposure patients, all three of whom were awake, recovering, and, in the case of the heavy-set man in the work jacket, watching morning television with the focused attention of someone deeply relieved to be bored when Pete Okafor appeared in the doorway. He had not gone home. He was in street clothes, which meant he'd clocked out, but he was holding 2 cups of coffee from the place across the street, real coffee, not machine coffee, the kind that cost $4 and tasted like it. I went home, he said. Then I came back. Sara looked at the coffee. Why? Because I figured you were still here, and you'd had the bad machine coffee and you deserved better. He held out one of the cups. Also, I have a question, and I didn't want to ask it during the shift. Coffee. It was good. It was genuinely significantly better than the machine coffee. What's the question? Pete leaned against the doorframe. He looked younger, in street clothes. The uniform added something, a layer of professional distance that softened without it. You could have left last night, he said. When Thorne told you to go, you could have walked out and filed a complaint and let the lawyers handle it, and you probably would have had a case. Probably, she agreed. But you stayed, even when it was getting worse. He looked at her with the honest curiosity of someone who wasn't asking rhetorically. Why? Sara looked at the man in the work jacket watching television. She looked at the 2 other patients, both sleeping. Because they were here, she said, and because I knew something that could help them. She paused. That's usually enough. Pete considered this. Okay, he said. Which was, Sara had come to understand, his version of a complete sentence. He pushed off the doorframe and headed back toward the elevator. Stopped once, without turning around, and said, I'm going to apply for the advanced practice program. Clinical ladder thing. Good, Sara said. You think I should? Yes. He nodded at the hallway and kept walking. Sara drank the coffee and watched the man in the work jacket laugh at something on television, a real laugh, the kind that moved his whole chest, which was a good sign physiologically and a good sign in general. She finished the coffee. She went back to the board. And it was there at 11:23 on a Friday morning, with the storm entirely gone and the November sun doing its week best through the ER windows, that she found the message. It was in the internal system, flagged as administrative priority, sent from a hospital address she didn't recognize. The sender was listed as Office of the Chief Medical Officer, Mercy Ridge Medical Center, a title that, as far as Sara knew, was currently vacant. Position had been open for 8 months, the search ongoing. The interim responsibilities distributed across the department heads. The message was 3 sentences. The board has authorized the creation of a new position, Director of Trauma Education and Emergency Clinical Standards. The role is intended to formalize expertise that should have been formally recognized some time ago. We would like to discuss this with you at your earliest convenience. Sara read it twice. She looked at the sender address again. Then she looked at the signature at the bottom of the message, which she had initially skimmed past. The signature read, Dr. Samuel Ozzie, Acting Chief Medical Officer, effective this morning. Put the tablet down on the counter. She stood in the corridor with the morning light coming in flat and clean through the windows, and she understood, not with surprise, but with the particular clarity of someone watching a long sequence finally reach its conclusion, that the institution was not just correcting an error. It was trying to build something new in the space where the error had been. She was still deciding what she thought about that when her radio clicked and the dispatch voice said there was an incoming trauma from a vehicle accident on the coastal highway, ETA 6 minutes, mechanism a rollover with an ejection, and the on-call trauma team needed to know if anyone on the floor had advanced airway experience because the patient's Glasgow score was coming in low. Sara picked up the radio. This is Nolan, she said. I've got the airway. Tell them I'll be at intake. She clipped the radio back to her hip and walked toward the ambulance bay, and behind her the message sat on the counter with its 3 quiet sentences and its offer of something she had not asked for and had not been expecting, and she would read it again later and think carefully about what to do with it. But first there was a patient coming in at 60 miles per hour with a low Glasgow score and 6 minutes on the clock, and that was the problem in front of her. That was always the problem in front of her. And she walked toward it the way she always had, without ceremony, without hesitation, and without any interest in being seen doing it. Patient came in hard. Ejection from a rollover on the coastal highway meant the body had gone through forces that didn't negotiate rotational, compressive, sudden deceleration, and then the ground. Paramedics had him on a backboard with a cervical collar and a bag valve mask being squeezed by a tech in the back, and his Glasgow score had dropped another point during transport, which meant the window was not staying open. It was closing. Sara was at the ambulance bay when the doors swung wide. 31-year-old male, the lead paramedic called out, moving fast. Full ejection, estimated 40-mile-per-hour rollover. GCS is 6. Airway is partially maintained, but he's losing it. He bit down on the oral airway twice. We couldn't keep it in. Pupils are sluggish bilaterally. BP 102 over 68. Heart rate 112. Sara fell into step beside the gurney. Any visible head trauma? Laceration occipital region, bleeding controlled. We're worried about the internal. How long down before extrication? Approximately 4 minutes. 4 minutes unconscious at the scene plus transport time. She ran the math without pausing, her hands already on the patient, assessing jaw tone, neck position, the alignment of everything she was going to need to work with. The oral airway hadn't held because his gag reflex was still partially intact, which was simultaneously a good sign neurologically and a complication for intubation. Bay 1, she said, I need RSI drugs drawn etomidate and sucks. I need the video laryngoscope ready, not the direct. And I need a second person in that room who's done this before. The day shift trauma nurse, a heavyset, experienced man named Carl Whitby, who had 22 years in the ER and moved with the economy of someone who had stopped wasting motion a long time ago, was already at Bay 1 when they arrived. He looked at the patient, looked at Sara, and started drawing medications without being asked. Dosings, he said. 0.3 milligrams per kilo etomidate, 1.5 sucks. He's approximately 80 kilos. You want me to push or manage the airway? Push. I've got the airway. Carl pushed. The RSI sequence took 90 seconds. Patient's muscle tone dissolved with the succinylcholine. The jaw relaxed, and Sara moved in with the video laryngoscope. Watching the screen instead of looking directly the camera angle gave her the chords before her line of sight would have, and in a patient with cervical precautions and an occipital laceration that hadn't been fully evaluated, she was not going to hyperextend to get a better direct view. Chords appeared on the screen. She advanced the tube. She watched it pass. Bag it, she said. Carl bagged. The chest rose symmetrically. She listened with the stethoscope bilateral breath sounds. Equal, clear. Confirm with waveform, she said. The capnography trace appeared on the monitor, the regular wave of exhaled CO2, the confirmation that the tube was in the right place and not in the esophagus. Good placement, Carl said. Secure it. Get me a portable chest and a lateral C-spine. And I want trauma surgery, paged. I don't like his pressure for a patient who's been down 4 minutes with that mechanism. Carl was already moving. Sara straightened and looked at the patient young, 31. Someone's person? A face she didn't know, and felt the particular weight of what this job asked of you. It asked you to be competent in the moments when competence was the only thing standing between this specific person and a worse outcome. And it asked you to do that without the luxury of being certain you were right, because certainty in emergency medicine was a fiction that got people killed. You worked with the best information available, and you moved. She moved. The trauma surgery consult confirmed her concern at 11:54. Portable chest showed rib fractures on the left side, 3 confirmed, possibly 4, with a small hemithorax developing in the left pleural space. The C-spine was clear, which allowed them to remove the collar and get a better look at the full picture. The pressure, which had been sitting at 102 on arrival, had drifted to 97 despite a fluid bolus. Trauma surgeon Dr. Ben Quartermain, who had arrived at 7 for the day shift, and had the particular alertness of someone who ran on early mornings and complicated cases, reviewed everything Sara had and made his operative decision in under 3 minutes. He goes to the OR, Quartermain said. Hemothorax? And I want to rule out a hepatic lac. The left-sided mechanism with that pressure trend. I agree, Sara said. Quartermain looked at her sideways, not dismissively, but with the recalibrating attention of someone who had just arrived to find that the clinical landscape had been managed before he got there. He had heard, in the way that hospitals moved information, some version of what had happened overnight. He hadn't formed a complete picture yet. You intubated him on arrival? He said. GCS of 6 losing the airway. Videoscope with RSI. C-spine precautions until your clearance. He looked at the waveform on the monitor. He looked at the tube position on the chest film. He looked at Sara with the expression of someone completing a calculation. Good call, he said. No qualification. Just the 2 words. Thank you, Sara said. The patient went to the OR at 12:19, and Sara updated the family a woman who turned out to be his older sister, who had driven from 40 miles away and arrived at the ER with her coat half on and her car keys still in her hand in the waiting room, with the kind of honest, careful language that didn't promise outcomes it couldn't guarantee, but also didn't hide behind clinical distance to avoid being human about it. The sister grabbed Sara's hand when she finished. Not dramatically, held it for a second, with the grip of someone whose body needed to be connected to something solid. Sara let her. The formal board review of Marcus Thorne's conduct was completed in 11 days. Sara was not present. For most of it, she was on shift for most of it, doing the job she had always been doing. But the findings reached her the way institutional findings always did, through the layered communication of administrators and colleagues and, in this case, a direct meeting with Dr. OC on a Tuesday afternoon in the second week of December. The review had examined 6 patient cases over a 14-month period. In 4 of them, the record showed that clinical observations from nursing staff, primarily Sara, but not exclusively, had been documented, and then overruled by Thorne without documented rationale. In 2 of those 4 cases, the subsequent patient outcome had been negatively affected by the delay in intervention. In one case, the effect was minor and correctable. In the other, a 57-year-old man named Walter Price had experienced a 12-hour delay in the identification of a developing bowel obstruction because Thorne had dismissed the nursing observation, and the patient had subsequently required a more extensive surgical intervention than would have been necessary with earlier detection. Walter Price had survived. He had also spent an additional 9 days in the hospital and experienced complications that the surgical team had documented as potentially avoidable. That case, Osei told Sara, was the one that had settled the board's decision. Thorne's hospital privileges were revoked, not suspended, pending review revoked. The distinction was significant and permanent. He would be referred to the State Medical Board for independent review, which was a separate process with separate potential consequences, and which the hospital's legal counsel had made clear was not something the institution had the authority to control or predict. What the institution could control was its own house. He'll likely find a position elsewhere, OC said. Physicians with his credentials usually do. The state board process takes time, and the outcome isn't guaranteed. I know, Sara said. Osei looked at her. Does that bother you? She considered the question, honestly, because Osei was someone who asked questions to get real answers, and she respected that enough to try to provide one. Yes, she said. A little. But the thing that bothered me more was the daily version of it, the accumulation of small moments where something wrong happened and kept happening. That's what the revocation addresses. The daily version. She paused. What happens to him after that is his to manage. O.C. nodded slowly. That's a mature position. It's just an honest one. He looked at her for a moment with something that was close to admiration, but was more specifically the regard of a person who had spent 40 years in medicine, watching people navigate the intersection of competence and institutional power, and who recognized someone doing it with their integrity intact. The director position, he said. Have you thought more about it? She had thought about it every day for 11 days. She had thought about it in the way she thought, about everything that mattered, not obsessively, but returning to it, turning it over, looking at it from different angles until she could see the shape of it clearly. I have some conditions, she said. O.C. almost smiled. Tell me. The conditions were 3. The first was that the Director of Trauma Education and Emergency Clinical Standards role would include a formal mentorship track, a structured program for junior nursing staff that provided supervised clinical development in advanced skills, not as a pathway to physician replacement, but as a recognition that nursing expertise existed on a spectrum that institutions routinely failed to develop because development cost time and time cost money. She wanted the program funded, not aspirational. The second was that Rafferty remain as charge nurse. Sara had thought carefully about this one, because Rafferty's choices during the previous 4 months were real and had consequences, and she didn't want to minimize them by acting as if they hadn't happened. But Rafferty had also done the harder thing, not just recognizing the wrong in retrospect, but standing up in a room full of institutional power and naming her own role in it. That was not a common response, and it was not a nothing response, and Sara believed in the pragmatic value of keeping people who were capable of that kind of accountability in positions where accountability mattered. Osei had raised an eyebrow at that one. You're advocating for the person who didn't support you, he said. I'm advocating for the person who corrected that when it counted, Sara said. Those aren't the same. The third condition was the simplest and the most personal. Sara's military background would be noted in her institutional record, but it would not be the frame through which the department was asked to relate to her. She was not a veteran nurse or a military medic who had become a civilian nurse. She was a nurse. The history was hers to share as she chose, and the role she was being offered was based on her demonstrated competence in this building, not on a record from a classified operation that was never going to be fully disclosed anyway. O.C. accepted all 3 conditions without significant negotiation. He did say, on the third one, with the dry precision of someone who had been in institutions long enough to understand how they processed information, the department is going to know regardless. People talk. People can know, Sara said. I just don't want it to be the headline. Fair, he said. She accepted the position on a Wednesday, in a short meeting that took less than 20 minutes, and produced a 2-page document that she read carefully, asked 4 questions about, and signed. She went back to the floor immediately afterward. Carla Mendez was transferred out of the ICU on day 9. Sara visited her on the general neurology floor on a Thursday afternoon between shifts, not as her nurse, because the ICU and the neuro floor were not Sara's units, but as the person who had first flagged her herniation in the ER 9 days earlier. She went because she wanted to, which was reason enough, and because there was something unresolved in her that needed to see Carla Mendez awake and present. Carla was awake. She was sitting up in bed with a tray of food she was eating, without notable enthusiasm, which was a completely reasonable response to hospital food. She had a slight word-finding difficulty that the neuro team was describing as likely temporary but monitoring carefully. Her husband was in the chair beside the bed, reading something on his phone with the particular posture of a person who had not left his wife's room for more than an hour at a stretch in 9 days. He looked up when Sara appeared in the doorway. Are you the one from the ER? He said. The nurse? I was her nurse that night, yes, Sara said. He stood up. He was a tall man, early 40s, the kind of tired that lived in the bones rather than just the face. We were told that you're the one who... He stopped because the sentence had too many endings and he couldn't pick one. Doing well, Sara said. That's what matters. Carla looked at her from the bed. The word finding difficulty showed briefly in her expression the slight hesitation of reaching for something and finding it a half step further away than expected. And then she said, I don't remember you. You were unconscious when we met, Sara said. But you're the reason I'm... Carla gestured vaguely, encompassing herself, the room, the fact of being alive in it. The surgical team is the reason you're here, Sara said. Just made sure you got to them. Carla looked at her with the careful attention of someone whose brain was working harder than usual and was not willing to be redirected by modest deflection. That's not what the neurosurgeon told us, she said. Sara stayed in the doorway for a moment. Then she stepped inside the room and sat down in the spare chair, because the conversation clearly wasn't finished. Standing in the doorway was a way of keeping her distance that these people had not earned and did not deserve. How are you feeling? Sara said. Like someone opened my skull, Carla said, with the flat honesty of a person who had decided that the appropriate response to nearly dying was not to pretend it had been anything other than what it was. But she paused, finding the word. Here, I'm here. Yes, Sara said, you are. Carla's husband sat back down. He put his phone away. The three of them sat in the quiet of the room for a moment, with the specific quality of people who shared something significant and were not quite sure how to hold it between them without making it too formal or too casual, both of which would have been wrong. Thank you, Carla's husband said finally. Just that, without trying to make it larger than it was. You're welcome, Sara said. Just that in return. She stayed for 12 more minutes, answered 2 medical questions they had about the recovery timeline, and left. In the elevator going down, she stood alone and let herself feel the full weight of the previous 9 days, for the first time since they'd happened. Not the professional weight that she'd been carrying and managing continuously, but the personal weight, the part that lived underneath the competence, the part that knew how close the margins had been. Carla Mendez in cardiac arrest at 3:51 in the morning, 4 minutes of a flat line, a rebleed that had been developing since the initial surgery. Roy Barker sitting in a waiting room chair while his spleen bled into his abdomen. James Reardon's pressure at 74 and 1 unit of blood left. The margins. She had operated in tight margins before. She would operate in them again. That was the nature of the work, and she had chosen the work with her eyes open, and she did not regret it. But she was also a person, not a machine, and being a person meant that sometimes, in an empty elevator, the weight of the margins arrived all at once, and you let yourself feel it. She felt it. The elevator reached the ground floor. Stepped out. She went back to work. The mentorship program launched in January. It wasn't large, because large things built on uncertain foundations fell over. It was 6 nurses in the first cohort selected by Sara and Rafferty together, based on clinical aptitude and the specific quality of being people who notice things, and it met twice a week in the education room, on the 2nd floor for 3 hours at a time, working through advanced assessment skills, clinical reasoning frameworks, and the practical mechanics of operating effectively in a high-acuity environment, when the resources and the time and the institutional support were not always going to be what they should be. Pete Okafor was in the first cohort. He showed up to the first session 7 minutes early, which Sara noted and said nothing about. He brought a notebook actual paper, which was unusual in 2024 among the younger nursing staff, and he wrote in it with the focused attention of someone who understood that what was being offered was worth the effort of actually retaining it. In the 3rd session, Sara was teaching the clinical reasoning sequence she developed from her military training, the layered assessment model that started with the environment before the patient, the system before the symptom, and she was mid-explanation when Pete said, without raising his hand, because that wasn't how the sessions worked, "Is this how you caught the herniation?" With Mendez, the room went quiet in the way that small rooms went quiet when someone had asked the real question instead of a safer version of it. "Yes," Sara said. "It's how I catch most things." You looked at how she was breathing before you looked at her neurosigns. The breathing pattern was a secondary sign of primary neurological compromise. If I'd started with the standard neurocheck, I'd have gotten normal variant results in the early herniation window and probably moved on. She looked at the room. The standard check wasn't wrong. It just wasn't sufficient for what was happening. The difference between sufficient and not sufficient was 1 level of observation. One of the other nurses in the cohort, a woman named Adele Sorensen, 36, who had worked oncology for 8 years before transferring to the ER and brought an oncologist's attention to subtle change, leaned forward. "How do you know which level to start at?" "You don't, always," Sara said. "You develop a baseline for what normal looks like in a given context, and then you pay attention to what doesn't match that baseline. The match or mismatch tells you where to look next." She paused. It takes time. It takes a lot of patience. It takes making the wrong call sometimes and understanding specifically why you were wrong. Have you made wrong calls? Adele asked. Yes. The room was quiet, waiting. I have made calls that were wrong and calls that were right for the wrong reasons, which is sometimes worse, because it teaches you bad habits, Sara said. The goal isn't to be perfect. The goal is to be honest about what you know and what you don't know, and to close the gap between those two things as systematically as you can. She looked around the room. Nobody in this field operates without error. The question is whether your errors are random or whether they're the kind you can learn from. You want the second kind. Adele wrote something in her own notebook. Pete underlined something. Sara moved on to the next section. In the third week of January, the State Medical Board notified Mercy Ridge Medical Center that it had opened a formal investigation into Dr. Marcus Thorne. The notification was procedural. The board was required to inform institutions when investigations were opened into physicians who had held privileges there. It didn't predict an outcome or a timeline. Medical board investigations moved slowly, and the results were not guaranteed, as OC had said. Sara read the notification when it came through the administrative channel and then set it aside. She was asked about it by Rafferty, who mentioned it with the careful neutrality of someone not sure how to characterize how they felt. Change anything for you? Rafferty said. Sara thought about it. Not really, she said. What needed to change here is changed. What happens in his life after that is the board's question. Rafferty looked at her for a moment. You know what I keep thinking about? What? Walter Price. Rafferty said the name with the weight of someone who had spent time with it. The bowel obstruction. He was here, for I was the charge nurse on the nights he was here. I remember him. He was a retired electrician. Brought his own crossword puzzle books. He used to ask the night nurses to check his answers. She stopped. I didn't catch it either. I saw the nursing notes about his abdomen, and I didn't push back on Thorne's assessment. Sara looked at her. I keep thinking, Rafferty said, about the 9 extra days he spent in this hospital. His wife was here every day. She slept in that chair. She gestured toward the corridor, toward the general direction of the inpatient units. 9 days. Yeah, Sara said. I'm sorry I didn't back you up earlier, Rafferty said. I've said it, but I want to say it again, because I don't think once was sufficient. Once was sufficient, Sara said. But I hear you. Rafferty nodded. She turned back to the board. The board had 19 patients on it, and 3 of them needed attention. They went back to work. James Reardon sent a card in February. Not a formal military communication, just a card, the kind you bought in a drugstore, with a Pacific Northwest landscape on the front that he had probably chosen because it was the closest thing to where he'd been when everything happened. Inside, he had written in the careful handwriting of someone who had thought about what they wanted to say before they started writing, so they didn't have to cross anything out. I was told you found the bleed in 3 minutes. I was told my pressure was 74 when you got there. I have done the math on what those 2 facts mean, and I want you to know that I understand what they mean. They told me you left the military to have a quieter life. I understand that too. I hope Caldwell Bay is quiet enough. Thank you, Major. Or just Sara, whichever you prefer. Sara read it at the nursing station on a Friday morning, with the coastal light coming through the windows at the angle it always came in February, low and clear, and carrying none of the weight of the November storm. She put the card in her locker. She thought about writing back and decided she would, eventually when she had the right words. The right words hadn't come yet, and she wasn't going to send the wrong ones. She went back to the floor. On the last Friday of February, the department held a formal reception. It was not Sara's idea. She would not have organized it and would have deflected it if she'd been asked in advance, which was why Rafferty and Pete and Adele Sorensen had organized it without asking her in advance, which was either a conspiracy or a kindness, and she had decided to treat it as the second one because the first framing would have made her angry, and she wasn't. The education room on the second floor had been rearranged. There was food from the place across the street, real food, not hospital food, and someone had put up a banner that Sara read once and then pointedly did not look at again, because it was the kind of thing that made her face do something she didn't entirely control. Most of the ER staff was there, both shifts, which meant people had come in on their off time, which was the thing that actually moved her more than any formal statement could have, because off time was real and scarce, and people didn't spend it on things they didn't mean. Carl Whitby was there, eating a sandwich with the comfortable presence of a man who belonged wherever he decided to stand. Adele Sorensen was there with other Sorensen, with the other 5 members of the mentorship cohort, standing together in the way that people stood together when they'd been through something shared. Dr. Amara Solis was there, which was a surprise. She had come from the neuro floor still in her white coat, which meant she'd come between cases, which was a different kind of choice than coming in on off time, but was its own kind of statement. Dr. Ben Quartermain was there, drinking coffee, talking with Carl Whitby about something unrelated, which was exactly how Quartermain participated in everything present, but not performative. Dr. Howard Strauss said a few words. He was not a natural public speaker, which made the words feel more honest. He talked about the night of the storm in terms that were institutional, the mass casualty event, the response protocols, the lessons being incorporated into the department's emergency procedures. And then he stopped the institutional language and said, plainly, "We did not recognize what we had in this department. It's on us. We're trying to do better." Dr. Osi said fewer words. Sara and said, "The best institutions are ones that can be corrected." This one corrected itself, largely because one person refused to accept the alternative. He raised a cup of coffee. To the person who refused, the room raised whatever they were holding. Sara stood in the middle of it and let it happen. She was not graceful about it. Her face did the things she didn't control, which meant her eyes were a different kind of bright than usual, and her jaw was doing some work, and she was grateful that the room was full of medical professionals who understood what it looked like when someone was managing themselves through an emotional moment and had the decency not to announce it. Pete was standing to her left. He was not looking at her. He was looking at the banner, spared her the added complication of making eye contact with someone who had been present for the actual events, and therefore understood what the banner meant in ways that the banner's text alone could not convey. She found her voice somewhere in the middle of the room's attention, and what she said was not eloquent. She hadn't prepared anything, because she hadn't known this was happening, and the prepared version would have been more polished and less true. "Came here to be a nurse," she said. That was all. "I didn't come here to prove something or change something. Came here because the work mattered and I needed somewhere to do it." She stopped, started again. "What I know is that the things that happened during that storm happened because of every person in this room who kept moving when it was hard. That's the truth of emergency medicine. You don't do it alone, and you don't do it perfectly, and you do it anyway." She looked around the room. "I'm glad I'm here," she said. "I wasn't always sure I would be." That last sentence came out more honest than she'd intended. Pete looked at the floor. Carl Whitby cleared his throat. Rafferty, standing near the door, looked at the middle distance with the expression of someone holding something carefully. It was enough. It was more than enough. Spring came late to Caldwell Bay. April before the temperatures made being outside something you chose rather than something you endured. But when it came, the coast was the kind of place that rewarded the wait. The light off the water had a quality that the inland didn't have, sharper, more horizontal, the way light got when there was nothing between it and the ocean to soften the angle. Sara drove to work on a Tuesday in April, with the windows down for the first time since October. She had a 700 shift, a mentorship session at noon, and an afternoon meeting with the hospital's risk management team about incorporating the advanced assessment protocol into the formal department training manual, the process of institutionalizing what had previously existed only in her head and the heads of the 6 people she'd been teaching it to. The work was different now. Not easier. The emergency department was not a place that got easier because the emergencies did not cooperate with institutional improvement initiatives. People still came through those doors broken and frightened and needing someone who knew what to do. The winters on the coast still produced storms. The highway still produced accidents. Port still produced industrial incidents. But she walked through the department differently than she had in November, not with more authority. Authority had always been available to her. The question had been whether the institution was organized to recognize it. What had changed was simpler than that. She walked through the department as herself, without the daily effort of managing how much of herself was visible, without the small calibrations of someone who has learned that being too competent in the wrong direction costs more than it returns. She walked in, and the department organized itself accordingly. That was not a small thing. She had spent years not understanding why people who were less qualified and less careful received more institutional deference, why loudness was mistaken for competence, why the performance of authority was so much more legible than the practice of it. She had spent years accommodating that confusion, managing around it, doing the work quietly, and accepting the invisibility as the price of staying. What she understood now was that the invisibility was not inevitable. It was a choice the institution had made, and institutions could make different choices, and sometimes what it took to make them make different choices was a storm and a night when everything broke at once, and the wrong people got to watch the right person work. That was not a lesson she would have chosen to teach that way, but it was the lesson that had been available, and she had taught it. Roy Barker came back to the hospital in April. Not as a patient, he was recovered, back to work on a limited basis. The surgical site healed, and the follow-up appointments behind him. He came back because he had told his wife he wanted to, and his wife had told him that was the right instinct. And so he came in on a Tuesday afternoon, wearing his work jacket and carrying a bag that turned out to contain enough food from the diner across from the port to feed 12 people. He found Sara at the nursing station. She looked up and recognized him immediately, the face she'd watched while asking him careful questions in the waiting room. The face that had been pale as old concrete on the monitor in Bay 9. He looked better. He looked like a man who had been through something and was on the other side of it. He set the bag on the counter and said, "I don't know how to do this kind of thing." "You don't have to do any kind of thing," Sara said. "My wife wanted to bring flowers." I said flowers felt wrong. He looked at the bag. "I figured people who work nights eat more than they drink." "That's accurate," Sara said. He looked at her with the steady, uncomplicated attention of a man who was not going to dress up what he wanted to say. "They told me I had maybe 30 minutes before I was in serious trouble. The internal bleed. The timeline was close," Sara said. She was not going to tell him it wasn't close, because it had been close, and he was someone who deserved honesty. "I was sitting in that chair, thinking I was tired," he said. "Just tired. I would have sat there until he stopped." "You didn't," Sara said. "Because of you." She held his gaze. "Because you answered my questions, honestly. You told me where the pressure hit first. You told me about the abdominal discomfort." She kept her voice even. "You gave me what I needed to work with. That's not nothing." He looked at her for a long moment. "Okay," he said, with the weight of a man accepting a version of the story that let him carry some of it alongside her. Stayed for 20 minutes. He ate one of the sandwiches from the bag, slightly awkward, standing at the nursing station, and talked to Pete Okafor about fishing, of all things. Because Pete had mentioned he'd grown up on the coast, and Roy Barker apparently had opinions about lingcod fishing that required sharing. When he left, he shook Sara's hand with the grip of someone who was saying something with their hand that they couldn't say with words. She shook back with the same weight. The bag fed most of the evening shift. There was a particular moment that Sara came back to afterward, not because it was the most dramatic or the most significant, but because it was the one that felt most true. It was a Wednesday early March, 6 weeks after the storm. She was in the hallway outside the education room after the second mentorship session, and the cohort had filed out, and she was standing alone for a minute collecting her notes. Adele Sorensen came back. She stood in the doorway for a moment, with the expression of someone who had decided to say something and was organizing how to say it. "In oncology," she said, "we have this thing where we watch patients get worse for a long time before they turn. You develop a kind of patience, I guess, for the slow-moving things." She paused. "The ER is different. Everything is fast. I'm still adjusting to that." "You're doing well," Sara said. "I know," Adele said, without false modesty. "I'm a good nurse. I've always been a good nurse. I just couldn't—" She stopped. Started again. "In my last department, there was a culture where nursing observations were collected and then essentially ignored, unless a physician independently arrived at the same conclusion. I had a physician tell me once that my role was data entry, not diagnosis." She said that phrase with the flat precision of someone who had memorized it because it had landed in a specific way, transferred out of that unit. But I carried something from it. Some version of that idea. That what I noticed only counted if someone else validated it. Sara was quiet. "What you did during the storm," Adele said, "and what you did before the storm for months, while Thorne was—" She stopped again. "You didn't stop. You kept noting things and escalating things and doing the work. And you stayed certain enough in your own clinical judgment to keep doing it, even when the institution kept telling you to stop." She looked at Sara directly. "How did you do that?" Sara thought about it honestly, because Adele deserved an honest answer, and not a polished one. "I knew what I knew," she said finally. not arrogantly. But I had seen enough in the military, in enough conditions that tested it, that I had a solid foundation for my own clinical judgment. And I understood the difference between being uncertain about a specific case, which is reasonable and appropriate, and being uncertain about whether I had the right to notice things and act on what I noticed. She paused. Thorne was trying to make me uncertain about the second thing. I knew the difference, so I didn't let him. Adele looked at her. "What I'm trying to give you," Sara said. "All of you. Not a set of protocols, not a list of assessment steps. The foundation underneath those things. The part that keeps working when someone with more institutional power than you tells you to stop noticing what you're noticing." She held Adele's gaze. "You're a good nurse. You've always been a good nurse. Trust that. It's not arrogance. It's the minimum required equipment for doing this job safely." Adele stood in the doorway for a moment. "Okay," she said. She left. Sara gathered her notes. Outside the window of the education room, the February coast was doing its February thin gray water, the kind of weather that felt permanent right until the day it broke. The light through the window was present, flat and real, and it fell across the table where 6 nurses had been sitting and learning to trust what they saw. It was enough. It was in the end the whole point. You did not need a storm to prove your worth. You did not need a dramatic crisis or a military helicopter or a night when the system broke down badly enough that your value became impossible to ignore. You needed to know what you knew, hold it without apology, and keep showing up for the people in front of you. The institution had failed Sara Nolan for 4 months because institutions could fail, because they organized themselves around power rather than competence, because they rewarded the loudest voice rather than the most reliable one, because they were made of people, and people carried their biases the way they carried everything else unconsciously, until something forced them to look. But the institution had also corrected itself, and Sara had stayed long enough to see it. Not because she needed the validation, not because she was waiting for someone to tell her she'd been right all along, but because the patients in that building needed someone who knew what she knew, and leaving would have meant they didn't have that, and she had never been able to make that math work in favor of leaving. She clipped her notes together, picked up her bag, and walked out of the education room toward the ER. There were patients on the board. There was always work. She went to do it.